Italy about another low-dose CT scan screening study in combination with blood microRNA. Sorry.
Good morning. We know from how can I advance this? Okay. We know that CT screening can reduce mortality. The question is how to use at best CT in a high-risk individual. The BioMILD was designed to evaluate the utility of a combined microRNA test on the blood and low-dose computed tomography to predict the individual lung cancer risk. So for a group of individuals with the same age, the same exposure, define those that are going to develop lung cancer. Assess the feasibility of a longer screening interval, so having defined the level of risk, decide different intervals. And of course, reveal if there is a potential damage in postponing the CT after 2-3 years in terms of stage 1 resection rates and interval cancer. We registered almost 10,000 volunteers. The inclusion criteria was 50, 75, 30-pack years, and stopping smoking from less than 10 years, so the usual. There were almost 5,000 eligible, and in the end, we enrolled 4,119 at baseline. In addition to MIRNA and low-dose CT, they had the spirometry and carbon monoxide. In essence, they were divided in 3 groups. A group of individuals with a double negative CT and MIRNA. The negative CT was set up at 112 cubic millimeter, which is a pretty high level. I mean, usually the threshold, the cutoff threshold is much lower, but in fact, this was adopted in 2013. The new Lung-RADS cutoffs just recently published use exactly the same cutoff, so 113 and 2060. The group of a single positive were individuals having either a lesion above or equal to 113, so indeterminate or positive CT, or intermediate or N or I MIRNA. Our test performs 3 different levels of risk, so low, intermediate, and high. The double positive were individuals having both a positive or suspicious CT and a positive MIRNA. Now, 58% of the individuals fell in the double negative group, 37, approximately 1/3, fell in the single positive group, and only 5% in the double positive group. The average number of CT was 2.0, 3.2, and 3.5 in the 3 groups. Sorry, I went down. I'm going backward. Here is the lung cancer incidence curves at 4 years. As you see, the risk of lung cancer is enormously different among this group that have the same composition of age, sex, and tobacco consumption. And the risk being almost 6 times higher in single positive and 37 times higher for the double positive. The difference is significant among each of the 3 groups. The mortality rates follow exactly the same feature, although they are, of course, much smaller, but the hazard ratio is 4.6 and 32 for the double positive. Of interest, incidence and mortality in the double negative at 4 years is very low, almost flat. So the take-home message is that blood microRNA and LDCT together can improve the screening, reducing the unnecessary LDCT repeats. But what is more important for us, the knowledge of an individual biologic risk can improve the efficacy of screening, but can guide prevention strategies, because the problem in a heavy smoker is not just detect lung cancer, it's reduce mortality. And so personalized prevention is a real option now, and that means diagnosis, but also preventive measure, smoking cessation, chemo prevention, and so the individual risk can trigger prevention in the future. Thank you.